Hello, and welcome to this special webinar event organised by the Institute for Musculoskeletal Health. My name is Adrian Traeger. I'm a research fellow here at the Institute, and I have the job of chairing today's discussion on how to change minds about health and medicine. Before we get into things, I'd first like to acknowledge the traditional owners of the land on which we all meet today. I'm coming to you from my home in the Hornsby area of Sydney, which is the land of the Darug and Guringai people. And I want to acknowledge their elders past, present, and emerging, and thank them for their custodianship of this land. Today is about challenging misconceptions. Misconceptions about health and medicine are everywhere, and most of them unlikely to be harmful. I think of the cures for hiccups my grandmother would have me try. Drink out of the opposite side of the glass, the far side. Then there are misconceptions that aren't harmless. The person who has diabetic complications because they heard that eating nothing but potato salad could cure arthritis. The person who chooses to have back surgery that has evidence of limited benefit, believing it would cure their pain. The person who drinks bleach to treat COVID-19. Now we see health misconceptions with broader implications for society. The global response to the COVID-19 pandemic has given us stark examples of these. For some, the misconception is loosely held, a curiosity or concern that dissolves rapidly in the face of new information. For others, the belief is held onto so tightly, it's almost as if it were attached to their identity. Then there is the added challenge of social media. Never before has misinformation spread so quickly and effectively. How do we, as members of the public, as those who provide or research healthcare, or influence public opinion, keep up? The Institute organised this discussion to find out how expert communicators deal with these matters. This is not your traditional panel discussion. We have a public health expert, a science reporter, an Outback newspaper editor, and a health communication expert. I'm not exactly sure where this conversation will take us, but let's see how we go. So I'm very excited to introduce our panel. First, we have Dr. Becky Freeman, who is a senior lecturer with the Prevention Research Collaboration at the School of Public Health, the University of Sydney. Welcome, Becky.
Hello, thank you.
Becky's primary research interests include tobacco control, food advertising, and how online and social media influence public health. We have Liam Mannix, who is the national science reporter for The Age and Sydney Morning Herald. In 2019, he won the Eureka Prize for Science Journalism, and just last month, he won the Walkley Award for feature writing for his reporting on COVID-19. Welcome, Liam.
Thanks for having me, Adrian.
We have Professor Julie Leask, who is a social scientist specialising in vaccination uptake. She is advisor to the World Health Organization and currently chairs the Behavioural and Social Drivers of Vaccination Working Group. She was named overall and global category winner of the Australian Financial Review 100 Women of Influence in 2019. Welcome, Julie.
Thanks, Adrian. Hi, everyone.
And finally, we have Clancy Overell, who is editor of the Betoota Advocate, arguably Australia's oldest newspaper. Welcome, Clancy.
Thank you for having me.
Okay, thank you very much for joining us, panel. And the way it's going to work today is we're going to discuss some things, and you watching from your computers can ask us questions on the Q&A. Giovanni and Charlotte, who work at the Institute in the top panel there for me, they're going to compile the questions, and hopefully we're going to have some time at the end to address some of the recurring themes. So please use that Q&A function on Zoom. And if you want to tweet about the event, our handle is @MSK_health, and the hashtag is changing minds. So I wanted to start with humour. We know that when it works, satire can humble the powerful and expose the ills of society. Many of you will have seen an attempt to dispel a myth regarding 5G networks recently in COVID-19. So I wanted to show a video, and then we can have a bit of a chat about that. Bear with me while I share this.
5G is spreading coronavirus. is a theory you might have heard on the dark web, or as it's currently called, Facebook. Now, there's a lot to unpack here, annoyingly. So, firstly, radio waves cannot spread viruses. If they could, someone would have weaponized Smooth FM years ago. Furthermore, from an electromagnetic energy perspective, my favourite perspective, 5G is in the same range as 3G and 4G. Just ask Telstra's 5G EME expert Mike Wood, who's studied electromagnetic energy for his entire professional life.
That's right, Mark. Viruses cannot travel on radio waves or mobile networks. 5G and other telecommunication radio frequencies do not affect the immune system.
Wow. Anyway, if COVID-19 was spread by 5G, then why do so many cities and countries yet to have 5G have the virus? Perhaps something else is spreading the virus, like, I don't know, the fact that it's a virus. People have also...
Okay, so there we have an example of satire to challenge a misconception that was spreading fast. So, Becky Freeman, is satire a good way to address misconceptions about health and medicine?
Oh, look, I think, as someone who often talks to Ministry of Health officials or other public health groups about what should we be doing with our campaigns, what they should look like, I would certainly never recommend to a government department you should use a satire approach to your public health communications, because they're just not professionals in this area. I mean, it would be ridiculous to think that public health experts would be good comedians, despite, how naturally engaging and funny we can all be. I just think you would never design a health communications campaign around that. But that's not to say that what we just saw and the work that, The Onion does or other satire news outlets do isn't part of the conversation. Of course it is. But I would never think that a public health body would have the skill set to do that nuance. And when you think about often how a lot of messaging and communications are formed, it's often by committee. It gets approved at different levels. A minister's got to sign off on it. An agency's involved. I think you would destroy any useful humor or satire that could possibly be used. So I'm thankful that we have experts in humor, satire, who want to take on these issues and do it so well. I'm not across, the literature on whether that impacts behavior and attitudes, but it must. Otherwise, why would these publications be so pointed and shared and cut to the issue so well? So yes, I think they're hugely important. I think they impact, but I would never suggest to any public health agency, you should take a satirical approach to this issue.
Well, they'd probably have to commission the right people if they did. They certainly wouldn't want to do the comedy themselves.
Oh, they would destroy their work though, because it would go through some sort of committee approval process and be cleaned and made unoffensive and all these things, and it would just be a disaster. So please keep that independent satirical voice completely independent.
Sure. And of course, the Mark Humphries piece was not for a government messaging. That was for sort of commercial purposes, which is, obviously beneficial to Telstra, I'd say. But we know that sometimes these satirical programs can change beliefs. There's been a little bit of work to show that programs such as John Oliver can change people's minds about climate change. Now, admittedly, those people in those studies, I don't think they were really at the one end of the spectrum that were complete climate change deniers. They were more agnostic about it. What about the role of publications like the Betoota? Clancy, I mean, you take on health issues fairly regularly. I have examples of the Betoota looking at fairly important issues like a recent headline, Nation, where GP appointments cost more than the president's tax bill say Medicare is communism. Another that said, Pete Evans now blind, suffering carbon monoxide poisoning after refusing to wear a welding mask. And my favourite, coronavirus-related stress levels reach point where mum has to break out emergency Enya CD. So, Clancy, can you tell us what made these health issues attractive to the Betoota?
Well, I guess a publication like ours just mirrors, what else you're seeing in the world. It's news in a sense. It follows the news cycle, and that was what we were kind of looking at, and everyone was looking at, and that's what everyone was thinking about. So it would have been bizarre for us to not cover, some of the bizarre things that we've all experienced, globally over the last 6 to 12 months. But as to the idea of bringing satire in, as you're saying, Becky, or bringing in any form of online content or online brands to speak to these issues and try and change attitudes and behaviours. I think particularly Australia, was kind of left in the dark a little bit. And we had the medical fraternity that was able to explain what this was and what social distancing was, and I feel like they were pretty open. But you've got to look at it from the perspective of the general public. No one knew who Norman Swan was until 6 months ago. So, I would say it shouldn't be up to comedians or even journalists. There should be ambassadors that they know Australian people love and trust. And funnily enough, that's not often politicians. I mean, it could have been Shane Warne. They could have hired him. He would have come out in the day and told us what 1.5 meters would have done. It could have been anyone. Mick Malloy. There could have been, a whole range of people, but that was kind of missed. And it's funny because I guess it's a result of us, everyone from policymakers to I like to think that, a lot of people in the medical fraternity knew what was happening and knew what we needed to do, but there was a feeling like everyone was building the plane as we were flying it. And so no one really knew how to do that and how to speak to the people about what needed to happen. But, you look back to the plebiscite and, the yes vote, the no vote, and how they managed to nail ambassadors at that time on a political issue that was cultural. But when it comes to something that was quite very, urgent and medical, it was really hard. And I think that's where all this started. This is where all these 5Gs started, and there was no one knew who to trust or what to believe. And, I found Norman Swan quite helpful. I found a lot of different people quite helpful at that time. But that was just me personally. I wanted to believe them.
So you think, using someone a bit more trustworthy than Mark Humphries might change more people's minds in Australia?
I don't think he was used. I think he was just I think he was just doing his thing as we were doing our thing, and I think it was great what he did. But I don't think anyone was specifically employed to get messages across, and I think that could have helped. Could have greatly helped.
Okay. So we know one of the issues with satire is, or one of the effects of satires is, it can sort of shame some people for their beliefs, and it can be funny, but in a sense it can kind of make fun of people who have absurd beliefs. And I guess that could have two effects. That could make the target reflect on their belief and change their mind, or it could make the target dig in and strengthen their belief and redouble efforts to prove those who disagree with them wrong. Liam Mannix, is there a risk that satire could have the opposite to the desired effect?
Yeah, without a doubt, Adrian. And Julie can expand on this, but I think the evidence is pretty strong now that shows that if people already hold a belief pretty strongly, making fun of them, talking down to them, satirising them is only going to harden them in their belief. And that's one of the real challenges with communicating with anti-vaxxers. But I think you guys, I'm conscious that we're talking to musculoskeletal health professionals here. By and large, you guys aren't talking to people with hardened health beliefs. You're talking to people who don't know a lot. They're members of the lay public, and they really like some expert health advice to help them out. And so I think if you think about talking to those people, what do you need to do? You need to get on their level. There's a lot of, I think in the general public, a sense that science is stuffy and that science is removed and abstract and difficult to understand. But it doesn't need to take itself so seriously. And I think you can have fun and enjoy a concept without, trying to be a satirist. I agree with Becky, leave that to the professionals, but you don't have to take yourself very seriously all the time. My favourite, or one of my favourite science communicators is a professor named James McCauley. He's a neuro and he works on back pain. And I remember chatting to him one day and he was like, Liam, it's impossible to slip a disc, right? And I was like, what do you mean, James? Everybody knows you can slip a disc in your back. I've slipped a disc. And he looks at me and he's like, mate, do you think your back's like a big bloody Big Mac with hamburger patty discs that just slide in and out?
Jenga.
Falling over all the time. And I was like, oh, yeah. Actually, that's a really good point. So he wasn't talking down to me, but he wasn't taking himself too seriously, and I think that makes him a terrific science communicator.
Fantastic. And great point. And I suppose that's, another emotion that we can use in communication, humor and lightheartedness is one, but another kind of attention grabbing way, maybe with discs as well, is to scare people into changing their minds. So we often see that in communication about back pain. We see it in other public health campaigns. So we're talking the other end of the emotional spectrum now, using fear or disgust. So I want to show you another video now, and we're going to just talk about that one. So just give me 2 ticks to line this up.
Good to see you, Amu.
You too, it's been a while. How's work?
Yeah, no, not bad. Alhamdulillah. Yeah. What do you reckon, guys? Time for shisha?
Alex, there.
Get us nargile, mate.
Come on, Dad, I'm playing soccer. Get someone else to do it, Dad.
Iman,
Oh, Dad, I'm uploading something.
Harin, we need the shisha here.
You want a food or shisha now?
We need shisha.
It's food time.
Oh, look at this. Shisha's coming. Shisha pa hai?
No, thanks.
Okay, so there we have a pretty different example about trying to change people's minds about a health issue. Becky, you were involved in the evaluation of that project there. So what about using fear? Is fear an effective way to communicate about health and change people's misconceptions?
Sure. I think, not to get all academic-y sounding, but I think negative emotional appeal is the sort of lingo we throw around. So if that was purely an information ad, if we had just been straight up with the facts, smoking a shisha is like smoking 100 cigarettes in 45 minutes. That it's just so forgettable. It's so academic. It has nothing behind. There needs to be an emotional angle to a message like that to make it discussion worthy, to make it stick with people, to have it mean something. It's like when you purchase, like say if a tobacco company was designing a tobacco ad, they don't just say, here is a stick of tobacco, you light it on one end and you smoke it. Like that would be, that's what public health would do as an information ad. There's emotion behind cigarette ads, right? You're adventurous, you're masculine, you're innovative, you're standing on the edge. And so public health equally needs to harness those emotions. And we have really good evidence in tobacco control in particular. Tobacco control, we're really fortunate. We've had well-funded campaigns similar to that. Most of you are probably familiar with the Every Cigarette is Doing You Damage ads, the graphic warnings on cigarette packs. Not all other health issues have had, the privileged luxury of having, 30 years of funded health campaigns, have had evaluation behind them, and can show clear behavior change. Unlike vaccines, however, you don't see an ad, get the ad injected in you and you're set for life, or you only need a booster every now and then. Those kinds of ads need to be on television, digital, radio, all the time, because something like quitting smoking or not taking up smoking is a journey, if you will, a reality TV term there. We're trying to get people to constantly think about making a quit attempt, taking a quit attempt. It's not like we think there's a magic ad, we're going to hit you with it this one time and then you're going to know smoking is bad and you're not going to smoke anymore. The evidence clearly shows having emotive appealing ads that rotate through, are on all the time, have high reach, those are the ones that are effective. Obviously, you need to balance some of those negative messages with, how do I get help? Where do I go? What will happen? What will be the good things that will happen to me if I quit smoking? We also know that there's some negative emotions that really don't seem to work and in fact can have a backwards effect. So in tobacco, we have emerging evidence that if people feel sadness when looking at one of those campaigns, it doesn't change their behavior, their attitudes, or their beliefs at all. And in fact, it can have the opposite effect. So there's nuance here. And I think fear campaigns, people think, well, show someone a disgusting lung and they'll never smoke again. It's not as simple as that. But the number one reason why people cite why they want to quit smoking, is because they are worried about their health. And so we're just listening to people. We're putting ads that we know will motivate them to do something they already want to do. Most smokers want to quit. Most regret having started. So it's a very unique set of behaviors. It's not the same as trying to get someone to go out and walk 15 minutes more. I think tobacco control is unique on that horizon. But I'll stop rabbiting on, because I could probably talk for 10 days on this topic.
So it's not as simple as just scaring someone to change their behavior, I guess.
Oh, I wish it was that easy. We would have fixed smoking by now. It would be done.
It's a much more nuanced approach.
Would you argue that you can scare people too much and kind of create a kind of a cultural kind of glitch? I mean, I remember obviously the Grim Reaper campaign caused a whole lot of other issues in society. And that was just another end of the spectrum, where you kind of, it resulted in, I guess, the ostracization of gay people and that, but then they kind of find middle grounds with these things, and you've got to kind of, I mean, there's a bit of trial and error too, I guess. It's not so much, communications aren't as black and white as medicine can be.
No, and I think that's a really good point about stigma as well. Because a lot of public health campaigning around behaviors is about social norms, right? We want the social norm to be that people don't smoke, or the social norm to be that, people don't drink sugary beverages. And the flip side of social norms is like, what you're doing, that's not normal. And it's a fine line to not stigmatizing individuals. I mean, I'm happy to stigmatize the tobacco industry, stigmatize cigarettes, that kind of thing. But stigmatizing actual human beings is not what public health should be doing at all.
Julie, can I bring you in here? Because I'm sure you have some views about using something like fear or disgust to encourage vaccination uptake. So, is that something that because you could show pictures of very sick babies, and I know people have done that before. So what's your view on using fear to change people's minds about something like vaccination?
So the evidence shows that it has a differential effect, like we're talking about. Actually, it's really interesting, Becky, to reflect on what you've been saying about tobacco control, because it's kind of like, well, how does it work? What's the mechanism? What's under the bonnet, the psychological bonnet of how it's actually working? And also reflecting on humour. And I wonder whether fear sets social norms, as does humour. It sets ways that we think you should think. And if you trust the bearer of that message and that you see them part of your social group, then it potentially affects behaviour. We know that fear of vaccine preventable diseases can affect confidence in vaccination. It can affect willingness and intentions to vaccinate. Whether you can take an intervention and use appeals to fear to get people to vaccinate, you'd be surprised how little evidence there is that works.
Sorry, can I clarify, Julie? Is that fear of the illness the vaccine is designed to prevent, or fear of the side effects of the vaccination? Which has the effect, or both?
I'm talking about fear of whooping cough to motivate people who are ambivalent to vaccinate their kids. And as I said, social norms are very influential, but fear is also, appeals to fear are influential in motivating vaccination. And you see in studies that you can potentially change people's intentions to vaccinate, but whether they actually vaccinate is another thing. And there's very little evidence that shows that appeals to fear get people to vaccinate. And it's possible that it's because of the groups you're targeting. So in vaccination, as you've alluded to, you've got the kind of the fixed people who will not vaccinate and then not going to shift. And you get that kind of backfire effect if you try. Then you've got the people who are very uncertain, and they're the ones that you might have an impact on with your appeals to fear. And the evidence shows that that alone is probably not enough. But one of the reasons why people don't vaccinate is because of practical and logistical barriers, and we don't focus on that a lot, but it's actually a big part of it. So if the problem is not people's motivation to start with, changing their motivation isn't going to make a huge difference. It might get them to try a bit harder to overcome barriers in life, but there are other ways you can get people to vaccinate. So it's a really interesting question, because intuitively, I know a lot of people think that if you just put more images of, babies with whooping cough in the media, you'll motivate people to vaccinate who are against it. And the evidence shows that you mostly don't. You can't use that alone. And it can backfire with people who are resistant to that message, because they're not going to act on it anyway, and they have to find some kind of defense mechanism against it because it pings your emotions really strongly.
Do you expect... Sorry, you go, Liam.
Sorry, Adrian, I was just going to ask Julie, in terms of where you spend your resources as trying to convince people of a public health message, you've got these groups, as you talked about, people who are very resistant, people who are unsure. Where do you get most bang for your buck? Like, who should you really be trying to target to get people to change their behaviour?
So our research suggests, and lots of people's research suggests, that you do two things. You focus on keeping people away from becoming the vaccine refusers of tomorrow. And you do that by focusing on their kind of what we call the entry points into expert systems. So the expert system is all of those people out there who have expertise in vaccination, and it's them who developed the COVID vaccine or whatever. And the entry point is often a health professional. So they're seen as the representative of that expertise. And so if you make sure that people's experience of health professionals and of healthcare is positive and constructive, that the health professionals address their concerns well, particularly if they're uncertain, then it can make quite a big difference, particularly if the health professional says, I hear what you're saying, here are the answers to your concerns, I'd really like you to vaccinate. A recommendation is powerful. So that's where we've been focusing a lot of our research, but also there's interest in focusing on before people become parents, say with childhood vaccinations. So even educating kids in school about vaccination, so they've got that stronger vaccination literacy. And also, interestingly, some people who are really skeptical of vaccination but may be willing to shift their thinking are more likely to trust complementary alternative medicine professionals. So you can go two ways. You can go, those people are not part of the scene and we want to sideline them, or you can go, let's try and engage with them because those people that we want to reach are listening to them. And there are certainly a decent proportion of naturopaths, homeopaths who agree with vaccination, you'd be surprised to hear. So that's another sort of area of potential interest for targeting. In terms of the messages themselves, it's very difficult with a single message to change someone who's harder to reach in terms of their motivation. It's much more about the way the choice architecture, the way you recommend vaccination, the way they see social norms happening, and what the health professional recommends to them.
And I'd just add, in the smoking incidents, there's parallels, but there's also big differences, right? Like, we know that most smokers do not get professional help to quit, that it's an internally driven behavior change. Most people quit cold turkey or on their own. And so if we relied only on health professionals or people who they interact with to advise them to quit, it wouldn't be that useful. But we also know that people who do need help, who do engage with health professionals, do way better if a health professional asks them if they smoke and recommends that they quit. So there's not like this one sort of archetype of the smoker who needs these kinds of messages. It's like you need a architecture of messages. Okay, so for the people who are going to quit on their own, those population level health messages that target blanket everybody, like warnings on packs and mass media campaigns. But if you were to go to see your physician and she or he is advising you to quit smoking, if they were just to show you a scary video or present you with a warning on a cigarette pack, that would be terrible clinical communication. That would just be ridiculous. So I think thinking about the different levels and messages that people receive is important as well.
Absolutely, and it's becoming more clear as this conversation unfolds that the source of the information is critical. So it's not just the style of the way you give these messages, whether you use emotion or not. It's the source becomes critical, and we might get to that later in the conversation when we start talking about trust. But I want to move on to the third technique that we had on our agenda, which was facts. So Liam Mannix, you're a science reporter. So is reporting science just about presenting facts, or do you need to use some techniques to kind of engage people as well, or is it just about the facts?
Yeah, really, the facts are sort of the underpinning bit that you have, but really science reporting is about telling a story. And I think that that's a really important sort of insight if you wanted to communicate about science effectively. Think about how the human brain works. We're born storytellers. Oh, is that audio coming from my end? Oh, sorry. We're born.
That might be my dog.
Oh,
sorry. Dog's feet on the.
You know, our ancestors were telling stories around campfires. Our brains are sort of built to pattern match, right? They're looking to pick a series of facts and then put those together into an internal story that they then tell us about the world. So if you want to communicate effectively, I think you really need a narrative to string your facts together into something that your brain can understand. And if you start thinking about your science that way, you can see the narratives emerge. So one of the narratives that's interested me is, you know, the problem with giving too many scans, MRIs, X-rays to people with back pain. They're overused. They tend to push people towards unhelpful surgery. Now, alone, that's sort of a collection of pretty dry facts. But what's the narrative? How about we live in an industrial, mechanical world these days, and so we've instinctively come to see our bodies as machines. When something hurts, you have a scan, you find the broken part, which might be a disc, and then you fix it, perhaps with surgery. But our bodies really aren't anything like machines, if you think about it. They don't really wear out from overuse. Just because they're hurt, that doesn't mean they're broken. And they have this amazing ability that machines don't have, in that they can heal themselves. So you sort of give people this counter-narrative. And then you ask yourself, who is benefiting from treating your body like a machine? Is it you, or is it the mechanic who's making money from this sort of worldview? So that's sort of one idea. But you can see how you can take a series of facts and turn them into a narrative structure. And you've even got a villain there. So, you know, I would encourage you guys to think about your science in this sort of way, in a way that people are attuned to, because there are stories in everything.
And I think if you look at your science writing, and we look at the piece that you just won the award for, the Walkley Award on COVID-19, you used a number of other techniques. So you acknowledged uncertainty, you used interesting metaphors to explain complex issues, like in your piece about COVID-19, you used concepts and metaphors like harpoons, and it was just accessible and engaging writing. So, I mean, you can see that it's not just about giving people facts. You need the narrative, and you need some of those tricks to really pull the reader in. Clancy Overell, you're pretty good at doing that as well at the Betoota. How do you make facts more engaging?
I guess it's one big issue for communicating right now to, you know, with some of the big and kind of complex advice that is being handed out over the last 12 months. Some of it feels complex when you first hear it, and then eventually now, you know, social distancing and those kind of things are just everyday life. But I do think there is an issue in Australian media, and I guess in terms of just the way we take in information nowadays, where bite-sized is key. And we're seeing it now. I'm not sure if many of you have sat down and looked at TikTok, but that is some very, very short and sharp kind of parcels of information or content. And so I guess in that sense, you've got to narrow down what you're saying pretty quickly. And I mean, Liam, you made a interesting point about the journey. And I feel like, you know, obviously you won an award for that, and rightly so, because you were able to do that. But I know that you would have been thinking, how am I going to keep them captivated from each paragraph? How am I going to keep them engaged from each paragraph? And that's just the way it is. And it all started with Napster. The moment we could get our favorite song, the moment we wanted it, we were, I guess the gratification, instant gratification of content and the internet has just changed the way we're calibrated.
Yeah, you're spot on. You just can't lose people even for a sentence, even for a moment. If you're writing something and you're thinking, oh, this is a bit dull, then your reader's never going to get past it. And you see it with newspapers. We track eyeballs as they come down our pages, and we would lose the vast majority of readers, perhaps 25% of the way into a story. And that's working hard. That's working hard to keep people engaged. So engagement, making sure that you're constantly keeping that tension, that narrative tension turned up, that's the way to go.
I think it's interesting we talk about that, because being on the public health academic side, we write, 5,000 word papers that get published in journals that about 10 people read. Woo, great. And, but if I tweet something tomorrow, I might get 100 people reading it. And it's like, oh God, if 100 people read a research paper of mine, I'd be delighted. But from a messaging point of view, what we've known has worked so well in television broadcasts, that one-way journalism, or not journalism, sorry, one-way mass marketing. A lot of that evidence is falling down on digital. I know digital is not new. It's been around for a long time now, but we're quite slow in public health to catch up to these things. And it's really difficult to know which emotions to use now. It's fear, absolutely no, because fear, do you want your grandma to know that you've shared a video about lung cancer, or that you've liked something that shows a smoker dying? Like, social media has the performative angle as well. Like, people see what you've liked, what you've shared. So you have an audience as a reader or as a consumer. And I don't think we've wrapped our head around how to make that work in public health communications yet.
Yeah, Becky, I read a lot of academic papers. And
oh, thank you.
It drive me mad, because you guys, I don't know, for some reason, and I've spoken to a few scientists about this, the most interesting stuff is right at the bottom.
You got to save it to the end. It's the Easter egg you deserve for reading the paper.
So we're taught the exact opposite. You have to put your most interesting thing in your first sentence, because most of your audience aren't going to read past that point.
Could you imagine if my thesis has just been one line? Here's what it all means. Don't read anything else.
A 30-second video with you dancing.
I think I'm a bit old for TikTok, but it is a good format.
It's such a balance, though, between getting the detail across that science often requires and telling a story and engaging people. Like, we're juggling all of these things as scientists all the time. I want to move on to trust, because this sort of links in. So last month in the journal Nature, researchers at the University of Cambridge suggested the following, and I'm quoting, "We worry that the urge to persuade or to tell a simple story can damage credibility and trustworthiness." So these academics were concerned that getting those punchy messages across from the work that we do could ultimately undermine the trustworthiness of science, because you're skipping so much detail. So Julie Leask, this is really your area of expertise. Why is trust so important when you try to change someone's mind?
Because people ask themselves when they're hearing from you, who is telling me this, and can I trust them? And because the volume of information we have to process every day is so huge, we'll often use proxies to decide what to listen to and what to pay attention to. And one of the major ones is, do I trust this person, this politician, this organisation? And then I'll elevate that in my hierarchy of who I listen to, particularly with social media, because, social influencers, people who are highly connected in social networks, who have a lot of followers, who are seen as being, sources of important information. That means that what those people say can potentially have quite a broad spread. Whether it actually affects behaviour is another question. So trust is really important, but trust comes up a lot, particularly in qualitative research around what made a country end up getting spooked by a vaccine safety scare, right? So the MMR autism scare in the 2000s in the UK, a lot of people think that a lot of the stuff behind that, the past performance of government, was really pivotal in terms of it catching fire. And trust in government appears to be quite important in how people receive vaccination programs. Particularly, that will be the case with the COVID-19 vaccinations. So trust is big. And what we actually advise with trust is to not think about so much not to tell people to trust you, but to be trustworthy and to inhabit the qualities of trustworthiness. And there's some great scholars in this area like Ortwin Wren, who's a German risk communication expert, Michael Siegrist and Zing, who have written about trust in pandemics. And they say that past performance and values influence whether we trust people, which influences our willingness to cooperate with advice. So that was really crucial at the beginning of the pandemic. And it's going to be really crucial with vaccination. And it's one of the reasons why we advise with the COVID-19 vaccine that if, here's that communicating uncertainty, if it turns out from the phase 3 trials that those vaccines are looking safe enough and effective enough, then we want people to trust them, so they'll have them if they're recommended them. And therefore, we need to use influencers and people who are trusted within their networks. And if we see people who start in those networks who don't trust vaccination, we need to work with those people. Government does, or whoever is doing the advocacy does. So just quickly, the 5 components of trustworthiness. So focus on these. If you want to be trustworthy, focus on your competence, so your technical expertise, particularly if you're in government or public health. Focus on your objectivity, your fairness in representing all points of view, consistency, which of course has been really hard with the pandemic, having good faith and empathy towards others. And they can help you maintain your trustworthiness and prioritise things that make you trustworthy ahead of other things, even if that means acknowledging uncertainty, communicating early and often in times when you don't have perfect information, and admitting when you've done things wrong.
Can I just ask, Julie, how long has trust been such a large factor of the work you do? Such a big part of the work you do. Were you studying trust, or has this been something that everyone in your field has had to consider over the last 10 years?
So I've been looking at this since 1997, and trust always, it jumps out at you, particularly when you're using qualitative data, whether you're analysing media or you're talking to people, and it just keeps coming up at you and jumping out of the data, if you like. So if your question, Clancy, is about has there been a shift over time, I'm not sure I can answer that question. I know that it's pretty constant, and my belief is that people don't change too much. The mode of communication is changing a lot with social media. We're more exposed to divergent points of view, but how we trust and in whom we trust is probably pretty constant over time. That's my sense.
I wonder too, because I look at the other side, how products that harm us communicate and get us to trust them. And it's so interesting to me that brands like Coca-Cola, McDonald's, who, manufacture foods that harm us, that harm our children, are highly trusted brands. And they're the things like Julie said, their products are consistent. Their messages are all the same. You can rely on what you know you're going to get when you go there. They give you the same experience. And it horrifies me that these, commercial determinants of health are better at presenting trustworthiness in some ways. I don't know what my point is there. It's just something that occurred to me while Julia was talking at the horror that you can embody trustworthiness and not be it.
I think to pick up on Clancy's point, I think in politics at least, there's pretty robust evidence of a long-term decline in trust in institutions. And you see that coming out in the rise of the Tea Party first, now in the rise of Trump, in Brexit, in the UK, where there was a real sense that a vote against Brexit was a vote against experts, was a vote against institutions. And I think that is something that, science and that journalism really has to wrestle with going forward. But Julie, I do wonder if you're concerned at the move from the vaccine manufacturers to report all of their phase 3 data by way of press release. It requires me, every time I write a story about it, to say, but this data is from a press release and we should not absolutely trust it. As a skeptical journalist, you're sort of required to put that caveat in, but I do worry that I'm messaging the public to have less trust than they should in these vaccines.
Yeah, and thank you for being an ethical journalist, Liam, and thinking carefully about the impact of your reporting, like many of the specialist reporters do. Look, it's a trade-off. If you communicate early and often, including via press release, which is the only way they can do it until they can publish it, it's going to have the downside of people critiquing that approach. And, I critique that as well. It would be much better to have a very systematically reported set of trial data come out early. And why they're not doing that, that's up to them. But, I think that the trade-off is that you also get the early frequent communication that then helps people to get ready and for governments to plan. And that's important as well. So, I think we trade off those two things, the early frequent communication, albeit by not the greatest method, because trust in those companies is going to be so important. But I will note that the companies get that and governments get that and regulators get that. And in most countries, they are safeguarding public trust and confidence in those vaccines very carefully. And there's a lot of concern about how the actions reflect the trustworthiness of the process.
It's such a key issue with communication. I'm really getting that from the discussion. And we've had a lot of questions coming in. So I'm just going to take the last kind of 10 minutes of the discussion to send you some questions from the audience. So we tend to communicate the negatives in health to motivate people. For example, smoking causes lung cancer, obesity causes diabetes. The commercial marketers advertise the positives. Coke positions itself as youthful and fun. Can we do more of this in public health? Becky, do you want to have a go at that one?
Okay, well, I'll do smoking because it's the one I'm most used to. It's really hard to get people not to do something by emphasizing the positives. Do you know what? The worst campaigns ever, the ones that just make your skin go, oh God. You probably all remember these when you're about 13 years old and the health promotion educator would come in the classroom and be like, cool kids, don't smoke, am I right? And you're just like, oh God, this is just so bad. Like, please, no. Emphasizing like those positives it doesn't work for certain behaviors. However, if you're someone who's trying to quit smoking and you're engaging with a health professional and you're saying, I just feel like I'm going to relapse. What's the point? You're like, okay, let's go over the things. How much money have you saved? How does your hair smell? What does your house smell like? Are your friends and family proud of you? Like those sort of reminders of that cognitive behavioral prompts of these are the positive reasons why I'm doing this can be hugely helpful. But on like a mass media population trying to get people not to take up smoking, to quit, we don't have good evidence that does much.
There's some evidence in vaccination that when you use a gain frame, like when you frame the message in terms of what you gain from vaccinating, you're more likely to get people to want to vaccinate. But when you do a systematic review, there's no difference. So it doesn't really seem to matter once you put all the evidence together. So what we do find is that we're encouraging, media organisations to try to avoid using for vaccination stories pictures of needles going into arms because it ignites people's anxiety and that can be a bit of an issue around people delaying vaccination. So, you know, healthy, happy images of children, the ultimate goal of vaccination or of adults, is better than this sort of the kid crying while they're having a needle.
I find the idea of death is travels fast and wide. You know, I looked to Samoa where those two babies died in 2018 purely because of human error, and how within the space of 6 months, you know, the vaccinations dropped to 35% from 75%. And I just find, I just think, you know, and then the year after that you get a measles outbreak. When you do talk about death as the worst thing ever, when for whatever reason there is a counter argument presented, that can get highlighted and that can travel the world in minutes. And I don't know. In terms of messaging, it's the what can you gain from a vaccination sounds like a very hard one to pitch, but it also sounds like it could be quite effective.
Yeah, and you're right, Clancy. I mean, I was in Samoa in January helping with the measles recovery, and once they had a big outbreak and people were scared of measles, you saw massive demand for vaccination. So at a population level, you know, fear appears to have can have a big impact. But there wasn't a lot of, the vaccine hesitancy came from that administration error. It wasn't anti-vaxxer campaigning like a lot of people report. So the reason for that fear was, you know, there was something scaring people off the vaccine to start with. And in fact, the parents who lost their children from the vaccine administration error ended up coming out in public and saying, please vaccinate your kids. We know this wasn't intrinsically about the MMR vaccine. And that was part of the powerful sort of messaging that turned things around. But the government were just too slow to start up the vaccination program, and that was the major problem.
Can I ask about, sorry, Becky, I was just going to jump in and ask about some research from Sydney Uni from the Health Literacy Lab that found that young people believe that the threat of COVID-19 is exaggerated. So I wanted to get a quick answer from each of you on which strategy you would advocate to try and convince young people that COVID-19 is a real threat to the community. Maybe, Liam, how would you think the government would best approach that issue or addressing that misconception?
I'm just trying to remember what the researchers told me about this. I think we read a story. I think the message you need to communicate is that you're doing it for a group. You know, you're not doing this for yourself. You are doing your civic duty, and that was it. Actually, I think Macquarie did some surveys of social distancing during the pandemic, and it found that the people who did the best at social distancing were those who had a really strong sense that they were doing the right thing for their community and that they were caring for people. They were caring for their elderly and their vulnerable, and that was the message that works the best for them. So I would suspect that would be the way to go for those groups. But that also gets into the fear problem, because if you run a messaging campaign predicated on fear while also having this fact out that for young people the mortality rate is extremely low, although there are long-term risks, young people are going to look at that and say, well, hang on, this is inconsistent. You guys are running a fear-based campaign, but the evidence really is that the mortality threat to me isn't that high. So I think you need to be sensible about your messaging campaigns rather than just trying to scare the pants off everyone.
Becky?
Look, I echo mostly what Liam has said, for sure. And just a shout out to Kristen and Carissa's work there that they're doing. It's fantastic. I would say again, social norms, I know I've said it before, like the social norm is that we look after everybody, that we do our part to keep vulnerable people safe. We do our bit. And fear campaigns do not need to be untruthful either. Like, you can be honest. You don't need to exaggerate. Like, we don't have to exaggerate how bad smoking is. We don't need to make people think that, you know, everyone's going to die if they get COVID in order to be effective. I don't think exaggerating or misleading people is part of a fear message. A fear message still needs to be honest and based in science. It's just that it has an emotion wrapped around it to get people to pay attention to the science behind it.
Clancy?
Sorry, go ahead, Clancy.
Oh, you go ahead. Sorry.
Thanks. Yeah, a shout out to Carissa Bonner and Kristen Pickles, who are on the call, and Kirsten McCaffrey led that research. You know, that people are trying to get funding to trial these very questions, and they can't, because the Medical Research Future Fund, for example, puts less than 1% to behavioural communication research. So we actually don't have good, strong answers to this question. But some early trials from the UK around what messages were more compelling around COVID prevention showed that appeals to protecting others, so altruism, can have an impact. But certainly appeals to what's a social norm, like to be a good young person, you know, help look after your older relatives, is probably going to be the most compelling thing you have. But, you know, there's still a big question mark around this because we can't get funding to run the trials.
Even what it's not even just the message, but what platform should that message be on? Who should be saying that message? Those are equally researchable questions.
So much to be done and so little research money. Clancy, final thought from you?
I mean, I didn't want to go here, but I do think there's a little kind of sleeper issue politically, similar to what we were saying about Samoa and how there had been faith lost in that government and their healthcare system prior to, you know, the measles outbreak. I do think it was hard to communicate to young people that this is just as important for them to take part in, and COVID-19 was just as much their duty as it was everyone else's. And I think that is because, politically speaking, we just finished a tumultuous 12 months before COVID-19 kind of broke out, and it was related to you know, there was the negative gearing, there was, you know, the Richard Cook article, there was this idea of a boomer supremacy. So when you told everyone who was under the age of 50 in Australia that they had to stay indoors because old people were at risk, they said, well, that's been our entire experience living in Australia for the last 20 years.
Yeah, and look, this kind of these issues are so complex, and they take place in very complex political environments, and I'm conscious of time, so I think we might need to leave it there, but I just wanted to say a final thank you to our panelists for such insights and for being so generous with your time. And we're going to do a research study to try and explore some of these things, so please participate in that if you get an email from us. I wanted to also thank the team that helped organise today, Courtney West, Charlotte McLennan and Giovanni Ferreira, who are the team of the Institute who helped put it together. So big thank you to the team who did that. And of course, a shout out to Kristen Pickles and the team at the Sydney Health Literacy Lab, who were the inspiration for today's event. So thank you. And thank you everyone at home for joining us. I'm sorry that we need to wrap up. I'm sure we could chat for much longer. And big thank you for joining us, and thank you to the panelists. And we'll say goodbye.
Thank you, Adrian, for being a great host and moderator.
Oh, pleasure.
Thank you.
Okay, bye.